Good afternoon, everyone. Today we are going to take a class about benign oral lesions, and this includes ranula, dermoid, Ludwig's angina, like that. Before going to the class in proper, just reminding you about the midline structures in the neck region, the hyoid bone, then the thyroid cartilage, then your thyroid gland in proper. Okay. The enumerating the swellings in the head and neck region, and which is of benign type, which is the most common type, or the serious one which to be dealt with is Ludwig's angina, then enlarged submental lymph nodes, sublingual dermoid cyst, subhyoid bursitis, thyroglosal cyst, enlarged isthmus of thyroid gland, pretracheal and paratracheal lymph nodes, retrosternal goiter, thymic swellings, and swellings from the space of burns, which include lymph nodes or lipoma, aneurysm of innominate arteries, like that. And going to the details of the each individual cases, first one we can take it, the Ludwig's angina. It presents as a brawny swelling in the submandibular region, which is with a inflammatory edema inside the mouth. Clinically, it may present with a combined cervical and intraoral signs that constitute the characteristic features as well as the accompanying halitosis. This is a picture which shows a Ludwig's angina. A lady is having a erythematous lower chin, you can see, and the causative organism is the virulent streptococcus, and it is associated with anaerobic organisms also. Sometimes it may be associating with other organisms inside the floor of the mouth. It encompasses both sides of the myohyoid muscles, edema and inflammation of the tongue, and tongue may get displaced backward, upwards and backward, and painful obstruction of the airway also can be a presenting symptom. Unless treated, the cellulitis may extend beneath the deep fascia layers of the neck or to involve the larynx, glottic edema, and it can lead to airway compromise. This is one picture which we can see this protrusion of the tongue with the fullness of the mouth, with the upward and forward pushing of the tongue, and this patient has underwent the tracheostomy. So you can see the tracheostomy tube there. Usually in basic level treatment starts with antibiotics as as soon as possible. Using intravenous broad spectrum antibiotics is used. In advanced cases, when the swelling does not subside with antibiotics, or a curved submental incision is used to drain both submandibular triangle. Actually, this is a IND, but it leads to with a extended incision, and this incision sometimes may be closed with putting a corrugated drain also. And this operation may be conducted under a local anesthesia also. Rarely tracheostomy may be necessary in cases of severe infections, as in the picture which I showed you earlier. Then going to the next topic, ranula. It is a mucus retention cyst rising from the sublingual salivary glands. It resembles a frog's belly. That's why the name is ranula. Okay, you can see the swellings in the submental in the floor of the mouth, and which is very much similar to the belly of the frog. It's a tense cystic swelling in the floor of the mouth, blue in color. It's brilliantly translucent, situated in the one side of the frenulum, or on the both sides. Submandibular duct can be seen traversing the dome of the cyst. There's a plunging ranula. Here the cyst penetrates the floor of the mouth, that is mylohyoid, to enter the neck. Therefore, there is a swelling in the floor of the mouth plus a swelling in the neck, resembling a dumbbell shape. This retention cyst may be arising from the sublingual or submandibular salivary glands. The neck swelling may be in the submental or submandibular region of the neck. You can see the swelling in the submental, and actually here it is in the submandibular region, which is extending to over towards the neck. And we can, in this case of plunging ranula, we can have the bidigital examination, and if we give pressure on one side, it will be felt on the other side, and in case of plunging ranula, it will be positive. Confirmation of the diagnosis is by ultrasound examination, and MRI can be done in case of large plunging granulas. Plain X-ray will rule out the causage of stones, or which is a cause for the retention of this. Complications of ranula: you may get infected, mechanical interference with speech, or difficulty in eating if it is much bigger in size. Treatment: in case of ranula, the excision of the cyst is the primary in case of primary cases, and if the cyst wall is not mature enough to excise, you can go for marsupialization also by just de-roofing and after once the cyst wall get matured, you can excise the hole. In case of plunging ranula, excision is preferred by a cervical approach. This is together with submandibular and sublingual salivary glands can be excised. In the next entity, we go for sublingual dermoid, and here we can there is a congenital anomaly as there is failure of proper fusion of the different layers, and a piece of skin may get entrapped deep to the midline just behind the jaw, and later from the dermoid cyst, formation of the dermoid cyst. The cyst may be in the midline or just lateral to the midline, usually presents from the 10 to 25 age. Both sexes are equally affected. You can see sublingual dermoid cyst by lifting the tongue, and it can be of two types: in the median, or which is in the midline, or in the lateral, and supramelohyoid variety and inframelohyoid variety. In supramelohyoid variety, the swelling will be in the floor of the mouth, whereas in the inframelohyoid variety, swelling will be beneath the chin, double chin, and this resembles a double chin appearance. On examination, there will be opaque white cyst in contrast to ranula that will not be translucent, and content will be sebaceous material. Present in swelling in the floor of the mouth or swelling beneath the chin. No, it will not be attached to in the cavern mucosa or the skin. The examination of the neck should be done properly in order to rule out the extension beneath the chin or laterally to the submandibular region. Biomanual palpation, the positive biomanual palpation suggests that the extension beneath the mylohyoid muscle. Its complications include infection, which will be painful later, then interference with eating and interference with speech also. The treatment of this kind of swelling is the complete excision of the cyst. If it extends below to the myloid muscle, a division of the mylohyoid muscles has to be done. If there is no extension to the beneath the chin, the intraoral approach will be sufficient for the enucleation of the cyst. Next, we move on to thyroglossal cyst, which is a midline swelling, which is in the line of descent of the thyroid. It is called thyroid gland. It may be extend for anywhere from the foramen of cecum to the isthmus. Usually, the tract will be obliterated in 5 weeks. If there is any remnant of this tract, it may develop into the cyst. This is the picture which you can see the tract by which it comes from the cecum to the in front of the trachea. So, and as the tract describes, it can occur anywhere between the base of the skull and the isthmus of the thyroid gland. The tract descends through the hyoid bone prior to the fusion of the hyoid bone in the midline. You can see thyroglossal cyst, just a small swelling in the midline, which will be moving with the deglutition and with the protrusion of tongue also. And the sites where we can see a thyroglossal cyst are suprahyoid, subhyoid, which is the commonest site, and at the level of thyroid cartilage, which is the second commonest position, and at the cricoid cartilage level beneath the foramen cecum in the floor of the mouth also. Treatment is it consists of removal of thyroglossal cyst along with the entire thyroglossal tract up to foramen cecum, and this is called cyst trunk operation. The central part of the body of the hyoid bone is excised during the process of the excision of the tract. In most of the cases, there is a tract which is lying behind the hyoid bone also. It is important to core out the entire tract in the floor of the mouth up to the foramen cecum, otherwise there will be recurrence. The thyroglossal cyst might change to a malignant lesion, and the key points to notice for the malignant transformations are recent rapid increase in hard inconsistency, fixity to the surrounding structures, and irregularity and presence of enlarged lymph nodes. Then you can have the next heading is subhyoid bursa, which is located below the hyoid bone in front of the hyoid membrane, and it lies transversely with the oval shape, moves up with deglutition, and soft and cystic in consistency. No translucent turbid fluid is no usual content, and it may be tender. Diagnosis is confirmed by the FNAC, and treatment is excision under local anesthesia. Pre and paratracheal lymph nodes. In the previous picture showed you the position of pre and paratracheal, pretracheal and paralaryngeal lymph nodes, and it may get enlarged in cases of acute laryngitis, papillary carcinoma thyroid, carcinoma of larynx, and in case of tuberculosis. This is in cases of suprasternal space of burn swelling. As I mentioned earlier, it can be a lipoma or sequestration dermoid cyst with iron swelling, or aneurysm of the subclavian or innominate artery, and it has to, all these things will be presenting with a swelling in the midline and with or without some obstructive features, and we have to diagnose it properly. Ultrasound is the basic investigation, and if needed we can go for CT also for the confirmation of the diagnosis. In all these cases, according to the extension, exploration and excision is needed. Thank you.